This conference will now be recorded.
Good morning, everyone. The previous class discussed regarding the cirrhosis and its complications, and I have mentioned that regarding the two important complications that are hepatic encephalopathy and portal hypertension. And among these two, why hepatic encephalopathy is important is because it is a short note as well as an essay question in your final year examination, both in theory purpose. It's an important short question, and sometimes it may also be asked as an essay question. So kindly take a note or attend. So why hepatic encephalopathy is important means because as in the previous class we have discussed regarding the alcohol and its chronic abuse, which leads to the various conditions like fatty liver, state of hepatitis, and stage of cirrhosis. And in the previous class I discussed regarding the cirrhosis, how it manifests and what is the pathogenesis of the cirrhosis, and as well as the complications, that is the long-standing complications. Among the complications, the two important complications, that is hepatic encephalopathy and portal hypertension. So these two scenarios should be known to each and everyone, because this hepatic encephalopathy, because this is purely one of the clinical entity. In a cirrhosis patient, in a long-standing cirrhotic patient who is in a wards, suddenly he may develop some antisensorium or any strixis or something. In that case, then we have to think in this encephalopathy, because of the compromise of the liver. Liver gets compromised, and this is damage to the liver cells. The mass of the functioning mass gets reduced. In these patients, metabolically this ammonium urea cycle gets altered or disturbed. As a result, this toxic ammonium ions, which are normally detoxified by the liver, doesn't occur in this condition. So that ammonium which is not detoxified leads to the damage, which damages the brain cells, which leads to the various encephalopathic features like asterixis or any altered sensorium or irregular talks like that. So we'll before going into, so just we'll see the outline. So outline we'll be discussing in the following headings like definition, types, etiology, pathogenesis, clinical features, Westhaven criteria, differential diagnosis, investigations, management, complications, and prognosis and prevention. See, coming to the definition, what is hepatic encephalopathy? What that exactly means portal systemic encephalopathy is a complex organic brain syndrome characterized by disturbances in consciousness, fluctuating neurological signs, asterixis of flapping tremor, and distinctive encephalographic changes, acute encephalomyelitic or chronic and progressive. So coming to the types, there are three types, that is hepatic encephalopathy associated with acute cell level failure, that is type A. Hepatic encephalopathy in patient with portosystemic bypass and no intrinsic, if there is no intrinsic hepatocellular disease, then it is type B. And hepatic encephalopathy associated with cirrhosis or portal hypertension or portosystemic shunt, then it is termed as type C. And in again the type C are classified into three types, that is episodic, persistent, and minimal. So among this, in episodic, there may be precipitating factors, or it may be spontaneous or recurrent. Where in the case of persistent, it may be mild persistent, severe persistent, or treatment dependent. So coming to the etiology, first part, that is etiology and precipitating factors. What are the causes that lead to the hepatic encephalopathy? Means, see, the first and foremost important is the increased protein load, that is increased GA load. Why increased protein load is important means because here as liver gets compromised, this detoxification does not occur. The proteins, this protein are not handled properly by the liver. As a result, this urea cycle get disturbed. As a result, these ammonium ions, which are toxic to the brain cells, these gets accumulated within the cells and lead to the damage to the brain cells. This is the main pathogenesis of this entire hepatic encephalopathy. So other causes that may lead to the hepatic encephalopathy are constipation, hypokalemia, infections, portosystemic shunting, and trauma, dehydration, or drugs like, especially like sedatives and antidepressants. So chronic parenchymal liver disease, that is other causes like intrinsic that liver disease like chronic hepatitis, cirrhosis, and fulminating hepatic failure like because of acute viral hepatitis, drugs like sedatives, sedative antipsychotics, alcohol intoxications like toxins. Example, Wilson's disease, that is copper, accumulation of copper. So surgical, coming to the surgical procedures that may lead to this hepatic encephalopathy, surgical like portal systemic anastomosis like portocaval shunts or transjugular intrahepatic portal system shunting tips, that is known as tips, and excessive nitrogen load conditions like because of excessive consumption of proteins or gastrointestinal bleeding, that is secondary to any esophageal varices. That esophageal varices may be because of the portal hypertension. That portal hypertension indeed is one of the complications of the cirrhosis. So, and other causes like electrolyte or metabolic disturbances like hypokalemia, hyponatremia, alkalosis, dehydration, excess vomitings. And coming to the infections like pneumonia, urinary tract infections, spontaneous bacterial peritonitis, and unknown causes like constitute around 20 to 30%. So, coming to the pathogenesis, main what are these pathological conditions that leading to the hepatic encephalopathy? Why means this shunting of portal blood directly into the systemic circulation by bypassing the liver. Why? Because what happens is whatever the blood that is portal vein that carries the blood from the different superior mesenteric artery, splenic artery, everything, this blood gets detoxified in the liver. In liver, what happens is this blood gets purified, that is detoxified, and then it will be sent to the systemic circulation. So, but what happens here is because the liver gets compromised, that is severe hepatocellular damage and dysfunction. In both circumstances, these toxic substances absorbed from the intestine, not metabolized by liver toxins. As a result, these toxins accumulate in the brain. So, what does it means? Means this because of this compromised liver, that is dysfunction. Because of the dysfunction, this portal blood that entering into the liver does not get detoxified. So as a result, this toxic blood, this spread to the entire body, that is through the systemic circulation, it reaches the different organs. That is one of the organs of the brain, which is very sensitive because these toxic substances that are nothing but the ammonium ions or the ammonia, these are very toxic, that it damages the brain cell directly. That too mainly there is the astrocytes. These are vulnerable reason because this ammonia, this urocycle does not occur properly. This gets accumulated and accumulated within the brain cells, and this leading to the further damage. So this is the main pathology. What happens is this the main reason is that detoxification of the blood does not occur in this liver. So because this procedure does not occur, these substances get accumulated within the brain. You have to understand this point. Because the detoxification does not occur, this entire pathogenesis occurs in the hepatic encephalopathy. So what are the toxic substances? I mentioned the toxic substance that is among the important one is the ammonia. Not only ammonia, because of this irregular process or because of the dysfunction of the liver, the following toxic substances that lead to the hepatic encephalopathy. Among them are the ammonium is a main substance, followed by methionine, mercaptans, short chain fatty acids, gamma aminobutyric acid, octopamine, false neurotransmitter substances, alterations in plasma levels of aromatic and branched chain aromatic acids. So see here you can see the flowchart, that is the pathogenesis, that is both in the acute and chronic condition. Basic cause is same in both forms, but the mechanism is somewhat different. Diminished detoxification of toxic nitrogenous compounds leads to the increased ammonium in the blood, which is toxic to the brain. Another one is the appearance of abnormal amines in systemic circulations. It interferes with the neurotransmission. So these are the two pathological conditions that is you have to remember. The first one is the because of the detoxification does not occur, there will be ammonium levels will be increased. So this ammonium level increase, which is toxic to the brain. Another one is the increase of the other toxic substances like aromatic amines that are very interfere with the neurotransmission. So what is this ammonia theory means? So how this ammonium is toxic to the brain cells, we'll see in detail. That is ammonia produced by the catabolism of amino acids involving two reactions, that is transamination, that is catalyzed by the aminotransferases, oxidative deamination. Second one is oxidative deamination, that is catalyzed by L-amino acid oxidase. Normally, ammonia is detoxified in the liver by conversion to urea by the Krebs-Henseleit cycle, and ammonia is also consumed in the conversion of glutamate to glutamine, a reaction that depends upon the activity of glutamic synthesis. The two factors that are contributing to the hyperammonia seen in cirrhosis is how this hyperammonia occurs means here because of this decreased mass of functioning hepatocytes, fewer opportunities for ammonia to be detoxified by the above process. So portosystemic shunting may divert ammonia containing blood away from the liver to systemic circulation. So how this ammonia here through portal systemic circulation, what happens is instead of the blood going to the liver, it directly enters into the systemic circulation because the hepatocytes get disorganized. As a result of cirrhosis, their architecture will be distorted. As a result, the blood will be shunting. That means it will be taking a bypass through the collaterals and it enters into the systemic circulation, thereby bypassing the liver. So here two conditions. One is the failed liver cells, as a result increased in the ammonia, and other condition is the from the GI tract like the bleeding, excess bleeding, everything like the increased protein diet, or there will be because of the constipation, or there will be excess of protein content food. These indirectly increases the ammonia. So these are the two conditions. So here you can see the pictorial representation, that is in the ammonia production ureacensis, and here you can see the ammonia metabolism status of liver dysfunction or uricide. So here this is the normal cycle. You can see here in the muscle that ammonia here whenever there will be patient gets any excess exercise or any seizure condition or any excess protein intake or because of the bacterial overgrowth. See, you can see here the ammonia and ammonia acids are generated. Here also from the gut the ammonia and ammonia acids generated. And here what happens is in the liver this urea cycle occurs and the urea is converted and urea is excreted from the kidney. So the excess urea is excreted in the kidney. So what happens in case of this, here we can say in the case of hepatic encephalopathy or any liver dysfunction, what happens is this urea cycle does not occur. So this urea cycle does not occur. As a result, this excess urea is not excreted through the kidney. So what happens is this urea which is not detoxified, or the ammonium acids, ammonia or the ammonia acid, these are not converted into urea. These ammonium ions will directly enter into the systemic circulation, and from there they reaches the brain cells, which are damaged or toxic to these brain cells. So because this is the main pathology, that is why we are terming it as hepatic encephalopathy. So because this encephalopathy features are secondary to the liver dysfunction, that is why this term arises, that is hepatic encephalopathy. So this ammonia continuation, this ammonia crosses the blood-brain barrier and absorbed and metabolized by the astrocytes, that is the cells in the brain that constitute 30% of the cerebral cortex. These astrocytes use ammonia when synthesizing glutamine from glutamate. Increased levels of glutamine increases in osmotic pressure and in the astrocyte swelling of the astrocyte, resulting in swelling. So this is entire method to understand this. What nothing but see what happens. These brain cells are nothing but this astrocyte. What happens is this. Normally, this urea will be utilized. This ammonia will be utilized by the glutamate from the glutamate. So glutamate synthesis occurs. So what happens is this excess ammonium ions, these cycles get disrupted, or they may not be converted into entire to glutamate. So this excess ammonium ions will be accumulated in the liver, that is the brain cells, that are nothing but that is astrocytes. So because of this increased glutamines, so what happens is these increased glutamines gets accumulated within the astrocytes, which are these are osmotic in nature. Means what these gets indrawing of water. These draws the water from the circulation. So what happens is this astrocyte will get swelled up. So because of the cell swelling, excess swelling, there will be lysis. So this is how the astrocyte get damaged in this process, entire process. So these large star astrocytes, these are the large star-shaped cells, are essential to the functioning of the CNS because they help maintain the proper composition of the fluids surrounding the neurons, and the only cerebral cell capable of metabolizing ammonia. So that's why it's important. See, here you can see the only cerebral cell capable of metabolizing ammonia is the astrocytes. Because these excess ammonium levels, these glutamine levels will be increased, and these glutamine cell excess levels that get accumulated. So this is how entire process, this is cycle. This is how in these patients with hepatic encephalopathy, they adopt a characteristic morphological feature known as Alzheimer type 2 astrocytosis. So here see, you can see from the ammonia, what happens is this glutamate is converted into the glutamines, and these glutamines, excess glutamines, what happens is this is the normal cell. This is the normal architecture of the astrocyte. See here you can see the projections. So this is the normal architecture. What happens is because of this excess synthesis of these glutamines, indirectly that is by the because of the excess ammonia, what happens is these glutamine cells will get accumulated within these astrocytes, and because these glutamines has an osmotic effect, they means they have the capability of indrawing of water. So because this water gets influx, that is enters into the within the astrocytes, so these cells get swelled up. So as a result, this is the functioning of the normal astrocytes gets disrupted. So coming to the clinical features, so we have discussed regarding the etiology as well as the pathology. Now coming to the clinical features, how the patient present to us. So disturbances in the consciousness is the main, that is disturbance in the sleep pattern, hyperammonia, that is earliest feature, and progress to inversion of sleep pattern. That is, sleep pattern get disturbed because these patients will be, they will be night time they are roaming in the wards and they shouting like anything, and the morning daytime they will be there somnolences, that excess sleep occurs in the daytime. So there will be impaired memory, mental confusion, apathy, and there will be no interest in anything. They do not derive any pleasure from anything. And other like drowsiness, somnolences, that is nothing but excess and daytime sleepiness. These patients will roam around in the night times, and the daytime they will be sleeping. There is somnoleness, and then sometimes they may lead to coma. So coming to the changes in the personality, what are the changes that personality changes that occurs in hepatic encephalopathy are nothing but these are childish behavior, irritability, loss of concern of family, an aggressive outburst, euphoria, defecating and micturating in inappropriate places, and pater hepaticus. So what is this pater hepaticus? We coming slides will see. This is not a characteristic for this is not pater hepatic is not a characteristic of encephalopathy. This is one of the clinical features. So don't get confused. Pater hepatic cirrhosis of liver, one of the signs of acute liver cell failures. They're here in cirrhosis that presently feature. Don't think that this is pater hepatic is a characteristic of hepatic encephalopathy. So this is a sore, musty odor in the breath due to volatile substances normally formed in the stool by bacteria. These mercaptans, if not removed by the liver, are excreted through the lungs and appear in the breath. Pater hepaticus does not correlate with the degree of duration of encephalopathy, and its action does not exclude hepatic encephalopathy. That's what I meant to say. So coming to the fluctuating neurological signs, what are the signs that are indicated by the hepatic side? There is a patient with slurred speech, constructional apraxia. What exactly means in coming slide I will show. What hypertonia, flapping tremors, that is asterixis, and exaggerated tenor reflexes, and bilateral extensor phantom reflex. So this is what apraxia means nothing but it's a known activity. The patient will be knowing that activity previously, but when now if you ask the person to perform the same activity which usually does in the previous times, he may not be able to perform that. So coming to the number connection test, what it means, useful, reliable, sensitive bedside test, helps to assess degree of encephalopathy and response to treatment. See what here means, if the patient ask the patient to from coordinate one by one numbers accordingly, after the one we have to go for two, but here the patient he may not construct that entire team. So one followed by two, two followed by three, three followed by four, like that normally we will do. But this, if they ask the patient to coordinate the numbers or connect the numbers appropriately or in a chronological order, what happens is the patient will not be able to do. So this is the main number connection test. This is the bedside important bedside test to assess the patient. So this is the one of the clinical entity that gives a clue for the diagnosis of hepatic encephalopathy. Coming to the next clinical sign, that is flapping tremors or asterixis. What exactly means? A non-rhythmic asymmetric lapse in voluntary sustained posture of extremities, head and trunk, and due to impaired inflow of joint and other afferent information to the brainstem, reticular formation resulting in lapses in the posture. So demonstrated with the patient's arm outstretched and fingers separated by hyperextending the wrist with the forearm fixed, and the rapid flexion extension movements at the metacarpophalangeal and wrist joints are often accompanied by lateral movement of the digits. So I'm not able to find this video, otherwise I would have shown clearly what is this exactly means asterixis. So absent at rest, less marked on movement and maximum on sustained portion, and usually it is bilateral, although not bilaterally synchronous, and one side may be affected more than the other. In coma, the tremor disappears and not specific for hepatic precoma. So this asterisk is, so not only this asterisk is this is also not a characteristic. See, these asterisks may be seen in some other conditions. What are the other conditions that where asterisks are seen means uremia, ventilator failure, drug intoxication like with drugs like barbiturates, phenotime, alcoholism, and electrolyte imbalances like hypokalemia, hypomagnesemia, and hypoglycemia. So here you can see the asterisks. This is the wrist joint is fixed here. You can see the proximal joint, carpo. Here the carpal joint is the metacarpophalangeal joints. Here the wrist you can see. So as I mentioned previously, that is there will be bilateral extensor reflex, that is Babinski sign reflex, positive, and here we can see the flapping tremor, that is asterisks. Exaggerated, all the reflexes gets exaggerated. So coming to the criteria, how will we grade the encephalopathy? That is hepatic encephalopathy. We will be grading into, that is 5 grades. That is from the starting from the 0. So what are these grades exactly means? That criteria, you remember the name. There is West Haven criteria. So what is grade 0? Minimal hepatic encephalopathy, lack of detectable changes. This is important. Lack of detectable changes in the personality or behavior, minimal changes in memory, concentration, intellectual function, and coordination. Asterisk is absent. So see here, this is a grade 0. Coming to the grade 1, will lack of awareness, shortened attention span, impaired addition or subtraction, hypersomnia, insomnia, or inversion of sleep pattern, euphoria, depression or irritability, mild confusion, slowing of ability to perform mental tasks. Asterisks can be detected. This is grade 1. What is grade 2? Lethargy and apathy and behavior, obvious asterisks is drowsiness, lethargy, gross defects in ability to perform mental tasks, obvious personality changes, inappropriate behavior, and intermittent disorientation, usually regarding time. So coming to the grade D, that is grade 2. Coming to the grade 3, somnolent but arousable, unable to perform mental tasks, disorientation about time and place, and marked confusion, amnesia, occasional fits of rage, incomprehensible speech, and this is grade 3. And what is grade 4 is coma with or without response to pain stimuli. So coming to the differential diagnosis, in some other intracranial lesions like subdural hematoma, intracranial bleed, stroke, tumor, and abscess. Why these are important means because in stroke patients also there will be some altered sensorium. We will be seeing a patient with altered sensorium, or because of the tumors or intracranial bleeding, there will be rise in intracranial pressure. Because of that, also we will be seeing some altered patient will be performing like they'll be having some altered sensorium. And other like drugs are in alcohol intoxication, toxic encephalopathy from alcoholic intake, such as acute intoxication, alcohol withdrawal, and Wernicke's encephalopathy. And toxic encephalopathy from drugs such as sedative hypnotics, antidepressants, antipsychotic agents, and salicylates. So metabolic encephalopathy such as hypoglycemia, electrolytes, and imbalance like anoxia, hypercarbia, and uremia, and infections like meningitis, encephalitis, and intracranial abscess are also for the differential DD of hepatic encephalopathy. And hyperammonia from other causes like secondary to ureterosigmoidostomy and inherited urea cycle disorders and post-Caesar encephalopathy. These are all the differential DD for hepatic encephalopathy. Coming to the diagnosis, usually one of the exclusion that 4 elements. These 4 elements include that evidence of advanced hepatocellular disease, extensive portosystemic collateral stunts are both, characteristic clinical features like forgetfulness, confusion, leading to stupor leading to deep coma, and fluctuating neurological signs, characteristic EEG changes. So these are the clinically these are the 4 elements that are in the diagnosis. So coming to the investigations, what are the investigations that are usually performed for the diagnosis of hepatic encephalopathy? Diagnosis is usually made clinically. There is no pathognomonic liver function abnormalities, because as the liver cells completely get disorganized or distorted, there will be no specific features like only there is particularly ALT rises or ALP that pattern does not occur. So there may be abnormality in any way. So there may be low albumin senses and sometimes everything. There may be complete abnormality. That's not these patients does not have any specific pattern. So there will be next coming to the usual findings are that are elevation of blood ammonia in about 90% of cases, and there will be hypokalemia and EEG, that is ultraencephalogram, CSF and CT scan by performing CSF analysis and also CT scan, and visual evacuation potential abnormalities in initial stages. These are the one of the frontline investigations that we will be going to do in the case of hepatic encephalopathy. So investigations to suggest liver disease, abnormal liver function test, and ultrasound suggesting liver tests are required, and ideally liver biopsy. And other routine investigations like hemoglobin, total counts, differential counts, ESR, random blood sugar, sodium, potassium, blood urea, serum creatinine, prothrombin time, and histological examination. So coming to the first investigations, that is how this hepatic encephalopathy patients CSF looks mean. It is usually clear, and there will be normal pressure, and there will be normal or increased protein concentration, and there will be normal cell count, raised levels of glutamic acids and glutamine. This is very important. So whatever exactly trying to tell is, In the as the astrocytes get swelled up and because of the excess glutamine, these will accumulate within the cells and the cells get swollen up. That is edema of the cell occurs and there will be lysis finally. So when you perform the CSF, you can see that raised glutamic acid, glutamine, then you have to suspect hepatic encephalopathy. So coming to the ultraencephalogram, ultraencephalogram shows no clear abnormalities in stage 0. Even if minimal hepatic encephalopathy is present in stage 1, 2, and 3, there are triphasic waves over the frontal lobe that oscillate at 5 heads, and in stage 4, there is a slow delta wave activity. At this juncture, you may not remember all these things, because just remember ultraencephalogram is one of the investigation that we'll be performing in the case of hepatic encephalopathy, and there will be different findings. That is based upon the stage 5 stages, that is stage 0, 1, 2, 3, 4. There will be different findings that need not to remember that triphasic waves occurs at what which stage, or delta waves occurs at the which stage. You need to remember. Just remember that ultraencephalogram. So bilateral synchronous slowing of the waves frequency with an increase in the wave amplitude from the normal rhythm down to the range useful for diagnosis and to assess a treatment occur early. Non-specific, however, in a conscious patient with liver disease or virtual diagnostic. So coming to the brain imaging, what are the imaging modalities that are required for the diagnosis? Means in CT, what happens is, as I mentioned earlier, that in astrocytes, because of this excess glutamine accumulation, the cell gets swollen up, that is edema will occur, and this edema can be clearly appreciated in the grade 4. Grade 4, that is in the CT imaging, in the grade 4 you can appreciate the cerebral edema. CT and MRI show cerebral atrophy even with apparently well compensated cirrhosis, and results are related to the severity of the liver dysfunction. In cirrhotic patients, increased signal in basal ganglia and T1 weighted images thought to be due to the deposition of manganese. Coming to the new MRI techniques, provide a non-invasive means of assessment of changes in brain volume and impaired brain function. Proton magnetic resonance spectroscopy detects changes in the brain biochemistry, including direct measurements of cerebral osmolyte, and PET scan has also been used in the study of the pathophysiology mechanism. So just remember that you do not remember all these sentences. Just remember, in the case of investigations, initially you just remember the CSF analysis. What happens in CSF analysis? You will be seeing the raised levels of glutamate or glutamates. So what happens in CT? In only just in the grade 4, and second, coming to the ultraencephalogram, you just remember that this ultraencephalogram will be required in staging the activity, staging the hepatic encephalopathy. That is stage 0, whether it is in stage 0 or 1, 2, 3, or 4, because this triphasic waves will be seeing in stage 1 to 3, and in the case of this delta wave activity that will be seeing in stage 4. Just remember that CSF glutamate levels will be elevated, and ultraencephalogram there will be different phasic waves activity. And coming to the brain imaging, that in the case of CT, in the grade 4 only, the grade 4 can be appreciated as cerebral edema. That too in CT scan, that is useful for early grading purpose. So remember these 3 investigations. So coming to management, how will we manage the case in a brief outline is that managing hepatic encephalopathy. First, we have to rule out the other causes. As I mentioned previously, that are the differential diagnosis for hepatic encephalopathy, that are the other causes, that is like hypoxia. If the patient presents with hypoxia, then we have to supplement oxygen, that's 100% oxygen. In the case of hypercapnia, that we have to get wash out of the CO2 levels through by intubating the patient or something. Exhaling the process, and in the case of acidosis we will be correcting with the bicarbonates, and in the case of uremia, what happens, we may go for dialysis or in other process. And sensitivity to CNS drugs and broad ultralight changes means that are hypokalemia. In the case of hypokalemia, we have to give the potassium chloride supplement, that is pot chlor. And in case of a seizure activity or stroke, we have to control the seizures by giving the appropriate anti-epileptics. And in case of other conditions should be ruled out, like Wernicke's Korofsky syndrome, intracranial hemorrhage, CNS sepsis, cerebral hypokalemia, pancreatic encephalopathy, and drug exhaustion. These are the other conditions other than liver cause. So next important step in the management of hepatic encephalopathy is identify the precipitating cause of hepatic encephalopathy. Because what happens is we cannot revert the process entirely. So what we can do is we prevent the precipitating. If we stall these precipitating factors, or we control the precipitating factors, this ongoing process will be stop. So as a result, this severity the patient may not go into the severe stages. So what are the precipitating factors? Sepsis, gastrointestinal hemorrhage, constipation, dietary protein overload, dehydration, CNS active drugs, hypokalemia, alkalosis, poor compliance with lactulose therapy, prior anesthesia, prior portal decompression procedure, bowel obstruction or LAS, uremia, superimposed hepatic injury, development of hepatic cellular carcinoma. So now, by identifying all these precipitating factors, we should control these precipitating factors and inhibit these conditions. And then how? What is the exact empirical treatment? So what we will do, the patients with the pharmacological modality treatment that with the hepatic encephalopathy means lactulose or oral dose of 15 to 30 ml twice daily. Rifampicin, oral dose of 550 milligrams twice daily. Neomycin, oral dose of 500 mg 4 times. Uses high doses with caution. So what happens is this bacterial overgrowth will be prevented. That's why we are giving here the neomycin, rifampicin, everything to control the bacterial overgrowth within the gut. And next is metronidazole oral dose of 250 milligrams 4 times daily, and vancomycin oral dose of 250 milligrams 4 times daily. Sodium benzoate and flumazenil can also be used. So coming to the first one is the subordinate treatment, and specific treatment aims at decreasing ammonia production in the colon, eliminating the treatment of precipitating factors. So coming to the drugs, like as I mentioned, that lactulose, that is L-or, and other things like L-ornithine, L-aspartate infusion concentrates. So coming to the proper treatment, that is hospitalization is mandatory, and airway, blood and circulation should be checked immediately and maintained, and we have to remove the cause or precipitating factor should be identified, and IV fluids like dextrose, saline and injection thiamine should be given, and maintenance of fluids, that is electrolyte imbalances should be corrected, like hypokalemia should be corrected, hyponatremia should be corrected, and we have to immediately insert the Ryle's tube, and bladder catheterization, and diet like restriction of protein diet, that is low protein diet and high glucose diet, and injection vitamin K, and constipation should be avoided, that is by giving the lactulose syrup. That is what I mentioned, that is the main action is, that is this is also one of the like osmotic activity. As a result, there will be constipation can be relieved, and antibiotics like neomycin, it causes ototoxicity and other side effect, that is, and other antibiotics like ampicillin, metronidazole, rifampicin. This metronidazole has a side effect like peripheral neuropathy. When compared to the rifampicin, it's a newer drug and it has a lesser side effects. The rifampicin only used as a second line treatment if lactulose is not effective, or so first primarily means this we should relieve this constipation, because when the food that gets accumulated with protein gets accumulated within the gut, what happens is if the patient gets constipation or is in constipation, what happens, because this excess protein diet that gets accumulated within the gut, what happens, this bacteria gets accumulated there and there will be excess bacterial growth. This is what the exam exactly the pathogenesis. What happens is excess bacteria growth, this will be converting into the ammonia, the ammonium synthesis will be increased, and this ammonia this is not handled properly by the liver. As a result, this is getting bypassed by this photosystemic, through the photosystemic cell it will be entering into the systemic circulation, and from there it damages the liver. So that is the main modality of treatment, or preventing this preventing the severity of this disease. Means what happens is exactly is we should prevent this constipation by relieving the constipation. This excess protein that within the food that may not be get lodged in the gut, it get because on relieving the constipation, this excess protein diet through the feces they get excreted. So that is the main modality. So if the constipation, after relieving of the constipation also, then the patient symptoms may not be, then we will have to give the second line of treatment, that is through rifampicin. The only used as second line treatment if lactulose is not effective or poorly tolerated. When added to the lactulose, the combination of two may be more effective than each component separately. And next, ultimately liver transplantation. So what is this exact mechanism of the lactulose? What happens? Lactulose means it's a non-absorbable disaccharide, osmotic laxative activity, and it reduces the pH of the colonic content and thereby preventing absorption of ammonia. This is the main, because entire class we are discussing through this word, that is ammonia. So ultimate goal of our is to we have to prevent the absorption of ammonia into the blood, because this ammonia is not handled properly by the liver because of its dysfunction. That is why whatever we give the treatment, we have to prevent this absorption of ammonia into the blood. So that is why this lactulose, which has an osmotic laxative activity, as well as it prevents absorption of ammonia. That is the main role that we are giving lactulose in these patients. Coming to the next preparation, that is preparation of L-ornithine and L-aspartate. it is used to increase the generation of urea through the urea cycle, a metabolic pathway that removes ammonia by turning it into the neutral substance urea. So it may be combined with the lactulose and rifampicin if these alone are ineffective at the control receptor. So what it is, what we discussed, the first one is we have to give the lactulose. If the patient the symptoms get not relieved, then we will add a next line treatment, that is rifampicin, that is 550 milligram per BD dose. Then also if the patient will not get relieved from the symptoms, then we have to give the next one is the preparation of L-ornithine and L-aspartate. What is the role of this L-ornithine and L-aspartate? As you well versed with this cycle in the biochemistry, that is in the first year, you will be seeing that what happens is L-ornithine and L-aspartate, it converts the excess urea, excess ammonia into the urea. So in this way, this excess ammonia gets removed. So next, coming to the last part, that is complications. So what are the complications that are commonly seen in hepatic encephalopathy? Is there is brain herniation, brain swelling, increased risk of cardiovascular collapse, kidney failure, respiratory failure, sepsis, permanent nervous system damage, that is to movement, sensation, or mental state, progressive irreversible coma, side effects of medications. Coming to the prognosis, so how whether the patient recovers or not, we'll see. The acute hepatic encephalopathy may be treatable, depends upon stages. That too. So as I mentioned, the grade 0, 1, 2, 3, 4, based on the patient is in which grade or the prognosis will be assessed. So the chronic forms of the disorder often keep getting worse or continue to come back, and both forms may result in irreversible coma and death. Approximately 80%, that is 8 of 10 patients, die if they go into a coma. So the recovery and the risk of the condition returning vary from patient to patient. So how will you prevent hepatic encephalopathy? So initially we have to remove the etiological agents, and then we have to counteract the precipitating factors. So that is, treating liver disorders may prevent some cases of hepatic encephalopathy, and avoiding heavy drinking and intravenous drug can prevent many liver disorders. Thank you. So you have to remember, just in a brief, what things to be remembered. I will say in a brief, just like it is, so that will be useful for writing if it gives in a short note or in a second. So coming to the definition, so you have to write the definition in brief, and types, as I mentioned, that is 3 types, that is type A, type B, type C, and again among this type B and type C, you can see the mild, persistent, and severe varieties. And coming to the etiological agent, as I mentioned, like toxic like drugs, alcohol, or any antipsychotic sedatives like that, and any chronic liver diseases or any hepatitis infections like hepatitis A, B, and C, like them, or any Wilson disease. So these are also etiological agents. And coming to the pathogenesis, the most important thing you should remember is, because this entire hepatic encephalopathy, the pathogenesis is, you have to remember that this excess ammonia, which is not detoxified by the liver, gets converted in this ammonium ions. This gets accumulated within the brain cells, that too astrocytes, and because of this accumulation, this ammonia will be converted into glutamines, and this glutamine gets accumulated. There will be osmotic activity. As a result, the cell gets swelled up. There will be edema, and finally there will be lysis. This is the pathogenesis of this hepatic encephalopathy. You should briefly you should remember. Then coming to the clinical features, you should be remember in a sequential order. Like first, there will be neurological disturbances. There will be speech disturbances, and there will be like movement disorders like tremors, like asterixis, and there will be poor incoordination, that is constructional apraxia. As I mentioned, that the like bedside number coordination test will not be done. So these clinical features you should be remembering. And there next, coming to the Westhaven criteria, you should remember this criteria. Just you have these used for grading the hepatic encephalopathy. So that is 5 grades from the starting from the 0, 1, 2, 3, 4. And coming to the differential diagnosis, like differential diagnosis, you should remember like seizures or any stroke patients, or there will be meningitis or any subdural hematoma, or there is any intracranial bleed, everything. So these are some of the differential diagnosis. And coming to the diagnosis, this is mainly you should remember that this is clinical entity, and based upon the 4 elements that I discussed previously in the slides, you can see that, and that clinical entity followed by some investigations. So coming to the investigations, you should be in a sequential order. You should remember, first you should perform any peripheral smear, like we'll see assessing the hemoglobin, how is the hemoglobin content. Then we'll be see the like metabolic and like random blood sugars we have to see, and any electrolyte imbalances are there you have to see. And then we'll go for the next line. Don't say immediately CSF analysis. So first, initially we have to do the initial investigations, or the basic investigations like peripheral smears, electrolytes, blood urea or a renal function test like blood urea and serum creatinine, everything also we have to do, because these patients have a chance of landing into the renal failure. So next, followed by the investigations like CSF analysis. In CSF analysis, as I mentioned, you should remember the important point, that is glutamines will be elevated. And then next, coming to the ultraencephalogram, this you have to remember that in ultraencephalogram, this is useful for staging grade, that is grade 5. 5 grades will be there, that is 0, 1, 2, 3, 4. In 1, 2, 3 there will be triphasic waves, and in grade 4 there will be delta waves. You should remember just that's all. And coming to the imaging modalities, we can go for imaging like MRI, CT imaging, MRI, as well as the newer scans like PET scans. So among these three, just remember CT scan. What we'll be seeing, that in grade 4 there will be cerebral edema, which can be appreciated well. So this is how we will be investigating the patient. Coming to the management, you should remember the first we have to identify the etiological agents, and we should try to remove the etiological agent. Next, coming to the, we have to identify the precipitating factors. What are the precipitating factors? You should identify, and we have to get rid of the precipitating factors, or also or neutralize the precipitating factors. And coming to the main modality, that is the final one, is the supportive treatment as well as the pharmacological modalities. So what are the pharmacological modality? That is the first part, that is first important drug that will give in this patient is lactulose. What is the use of this lactulose? This lactulose, the patient prevents the absorption of excess ammonia, and also it has an osmotic activity. So if the lactulose, if the patient fails with the lactulose, then what is next? We have to give the patient, we have to give the rifamycin. Rifamycin, then also patient fails, then we have to go for L-ornithine aspartate preparation. So what is the use of this L-ornithine aspartate preparation? This L-ornithine aspartate preparation, it uses what happens is it uses the excess urea, excess ammonia, and it also converts this excess ammonia into the urea, which is neutral. So this is how you will be managing the case. And what are the complications, as I mentioned earlier, and what prognosis? How will you prognose the patient? You will be based on the grade. You will assess the patient whether he is in acute, whether he is in acute hepatic failure or chronic hepatic failure. So in case of acute hepatic failure, it's usually reversible. When there is a chronic condition, then we will, based on the grading, we will assess the prognosis. And usually, if the patient goes into the coma or everything, then he is not, almost he is dead. So coming to the prevention, how will we prevent the case? As I mentioned earlier, you have to first initially identify the etiological agents, and you should get rid of this any acute liver diseases that should be treated properly, and they should be treated properly. And in case of any patient is having any drug abuse or anything, that alcohol, that should be uh, the patient should be counseled, and we explain regarding the consequences of the chronic abuse. So this is how, just briefly, this is the way you have to learn or remember the any question, because what happens is you will be learning everything, but you will not be remembering anything. So what happens, if you read in a sequential manner, that is, if not only this hepatic encephalopathy, any part of medicine you have to learn in this manner. First, you should know the definition, or if there is any types, you should know the types, or you should know the etiology, you should know the pathological features, and then you know the clinical features, then the differential diagnosis, investigations, management. You should write this in a sequence order. If you write this like in a sequence order, you will get more marks, and also the examiner will be impressed. If you write like in a paragraph manner, without writing any side headings or subheadings, there is no use. So try to learn any concept or any topic in this manner. You take any topic, you just all write all the subheadings, and try to learn 1 or 2 points that are important points. So thank you.
Petreshkar classic was a